Hello. So as mentioned, we're going to go over today managing overactive bladder, kind of what initial treatments are, some new devices that are out there, and when you should refer to Urogyn or urology. So first, just a little bit about me. I grew up in Virginia, went to college and med school in Virginia, did residency in Navy and fellowship in the Navy, and then spent 21 years with the Navy. So I just retired recently. It treated me well, but I am glad that I'm out. And now I've been with Sibley for a year, Sibley Johns Hopkins. I'm part of the GYN Oncology and Urogyn division there at Sibley. So I work with doctors Tanner, Chernowski, Gruber, and Staples. For fun, I usually like to do things where I end up covered in dirt or paint or usually breaking something at my attempts at home improvement. But most importantly, I am open for referrals and I am happy to take any patients that you send my way. So another disclaimer, I am a urogynecologist, not a urologist. So the focus of this lecture is on patients who are born biologically female, although many of the treatments that I offer also pertain to male patients. But as a urogyn, I only see female patients. Also, other disclaimer: the information presented is for educational purposes, and the devices that I mentioned are neither endorsed by myself or by Hopkins. So first, we need to define what overactive bladder is, and it is defined by the International Continence Society as urinary urgency, usually accompanied by frequency and nocturia, with or without incontinence, in the absence of other pathology, meaning they don't have a UTI, they're not passing a stone. Urgency is defined by the International Urogynecologic Association as a complaint of sudden, compelling desire to pass urine, which is difficult to defer. And that's kind of considered the landmark or the hallmark symptom of overactive bladder. It is very subjective, so sometimes it could be hard to, quantify in terms of research and diagnosis. But first, what is normal for a female? I go over this a lot with patients because I often find I have patients that are referred or who come in complaining of urinary frequency, but when I delve into what they're actually drinking, I discover that their intake is like a gallon a day. And a lot of them will say, "Oh, I heard it helps you lose weight," or "I heard it's good for you." But a normal female bladder holds about 300 milliliters, and average intake for a female is about 2 liters a day. And then keep in mind, you also get your fluids from foods that you eat. So if you're eating a lot of leafy greens and vegetables, you get fluid from that. But with about a 2 liter intake, women should void about 6 times a day and 0 to 1 times a night. So anything beyond that, I try to rule out, are they voiding frequently with low amounts, which is more consistent with overactive bladder, or are they voiding frequently with normal amounts, which is more consistent with they're just drinking a lot, right? And this is a simple thing you can do with your patients. I had a patient referred the other day with bladder pain and complaining of like a slow stream, and I delved into her history, and she actually was drinking over a gallon a day, but only voiding like 4 or 5 times a day. So when I had her do a voiding diary, she was literally voiding a liter each time. So she was, markedly overdistending her bladder. So we worked on time voiding, and her bladder pain symptoms resolved as a result of that. So just a simple thing you can do to kind of differentiate, is this more a habitual issue or is it actually overactive bladder? So in terms of prevalence, this is very common. The range can be broad, but as much as 7 to 27% in men and 9 to 43% in women, but it definitely increases with age. And it's thought that, by the time people get in their 80s, about 30% of both men and women will have overactive bladder. It can be distinguished from other conditions such as excessive fluid intake by doing a voiding diary. And again, those with high intake who are going often, that's not OAB. That's just managing fluid and their overall volume. I also talked to them about nighttime voiding, because a lot of patients will complain about going a lot at night, and then you discover they drink right up until the minute they go to bed. So education about stopping fluid intake 3 hours before they go to bed, drinking the bulk of their fluid in the beginning of the day rather than the latter half of the day, can help with some of those nocturia symptoms. So, why does OAB occur? Now, I am not a neurologist, nor is this a lecture on the mechanism of how the bladder functions, but it's actually somewhat complex and involves both efferent nerve signals. It involves the parasympathetic sacral nerves from S2 and S3, acetylcholine and muscarinic receptors, the pudendal nerve, onus nucleus, which controls the voluntary sphincter relaxation, the hypogastric nerve, which inhibits voiding, then the pontine micturition center, which when inhibited allows for bladder storage. Then you have the periaqueductal gray matter in the CNS that links the afferent signals from the lower tract to the higher brain centers to allow you to have control and initiate voiding. And then, of course, the spinal cord that allows all that to communicate. So there's a lot of places along that pathway where things can go awry, and certainly neurologic conditions can interfere with that. Spinal cord injuries, Parkinson's, MS, that can ultimately result in OAB. But today we're going to focus more on idiopathic OAB, which means there's not one, underlying cause, no neurologic cause that's causing it. In women, it's thought to be multiple contributors. So it could be aging of the brain itself, some loss of gray matter. You have some loss of detrusor contractility and reduction in sensation of the bladder as we age. Loss of estrogen actually alters the bladder microbiome and results in decreased coaptation of the urethra, and even increased bladder permeability due to the estrogen receptors that are along the urethra and bladder. And then, of course, increased medical comorbidities as we get older. So things like obesity, diabetes, smoking, sleep apnea can all exacerbate OAB symptoms. So it's likely the litany of these things that contribute to what we call idiopathic OAB. But I do have patients, ask me a lot, well, why do I have this? And the shorter answer is it's more common as we age, but the longer answer is it's probably a number of factors that are contributing to their symptoms. So the basic OAB eval, of course, includes a history and physical, right? And then a urinalysis and a urine culture. So you just want to rule out urinary tract infection. Additional workup that can be helpful is checking a post-void residual, or how much is left like immediately after they void. Less than 100 milliliters is considered normal, but it also depends on how much the patient voids. So if the patient voids 800 milliliters, a post-void residual of 100 or 150 might be normal. So some people use they void 2/3 and 1/3 or less of that volume is considered normal. But in general, I kind of use consistently, if it's less than 100, it's considered normal post-void residual. But a post-void residual can be very helpful in determining whether a patient has retention. So just ruling that out, because sometimes people do have overflow incontinence. And, distinguishing that from OAB, just because sometimes those symptoms can be closely related. From a preventive medicine standpoint, there are, I'm sure if you're in preventive medicine or primary care, you know all these things already, but there are many medical conditions that can contribute to OAB or even stress incontinence. Obesity, of course, increases intra-abdominal pressure, making it easier for patients to leak, definitely for women because we have shorter urethras. Central obesity also puts added pressure on the bladder, which can make urgency and frequency worse. Constipation can definitely worsen OAB symptoms because there is an overlap in the nerves that innervate the rectum and the bladder. And when the rectum is full, it often sends a signal to the brain that the bladder is also full. So it makes it feel like they have to urinate when it's actually pressure from hard stool or from being constipated. And then pelvic organ prolapse can actually prevent adequate emptying of the bladder and can make urgency and frequency worse as well. I do always ask patients if they have sleep apnea, or ask them if they've ever been evaluated for it, because particularly for the nighttime voiding, because sleep apnea increases the atrial natriuretic peptide due to the body thinking it's in fluid overload. and that causes diuresis, particularly at night. And so if a patient is reporting to me they have a lot of nighttime voiding, I always ask about sleep apnea. And sometimes patients have classic sleep apnea symptoms, but sometimes they don't. And I tell people, like, I have a normal BMI and no medical comorbidities, but was just waking up with headaches a lot. And my doc said, "Hey, maybe we should get a sleep study." And I'm like, "Whatever, I don't have sleep apnea." And turns out I have sleep apnea. So I was saturating to the 80s, at night. And that's why I was getting headaches. But so sometimes patients that you wouldn't suspect even have sleep apnea actually have it. So I always think it's a good idea if they're having, particularly nighttime voiding, meaning they're waking up to have to go to the bathroom. It's something that I like to rule out with patients. I also ask if they are using their machines if they do have sleep apnea, because a lot of patients aren't compliant with their use. And so I kind of say, hey, we can treat your OAB, but if you're also not treating your underlying apnea, that nighttime voiding is likely going to persist. Anxiety and depression can also play a role in urgency and frequency. I have seen a lot of young women, like young meaning their 20s and early 30s, with overactive bladder symptoms. And, I kind of start delving in some of their other symptoms, and you find a lot of them have some pretty significant anxiety disorders. A lot of them get anxious about like traveling, and people, when they're, worried or having stress in their life, they find that they're going to the bathroom more frequently. So I do definitely think that there's a correlation between some anxiety and having some of these symptoms. And then there can be an association with smoking as well, and overactive bladder, as tobacco and nicotine pretty much are bad for every organ system. It also increases your risk of bladder cancer. So asking about that. Of course, genitourinary symptoms of menopause are definitely a contributor. I think we talked a little bit, earlier about how loss of estrogen can impact the urinary tract by thinning out the urothelium and reducing coaptation of the urethra. Certainly diabetes causing glucose in the urine increases polydipsia and can increase your urinary urgency and frequency. So ensuring that their diabetes is well controlled is very important as well. They'll continue to have those symptoms if they're spilling a lot of glucose in their urine. In terms of defining success, when you're talking about treating OAB, you kind of have to know historically what we said success was when you give patients medications, or even Botox or neuromodulation. So most research has defined success as a 50% improvement in their symptoms. So if you think about that, if someone is like, let's say they're leaking 8 times a day and now they're leaking 4 times a day, that's the definition of success. Way to go, the medication is working. But you can see that's why we sometimes don't have a lot of great compliance with medications, because, in a patient's eyes, well, I'm still not dry. That's not success for me. So it can be a little bit difficult to counsel patients on treatment options when, their definition of success might be very different from what we historically have called treatment options successful. So kind of setting that expectation when you're talking about treatment options can be helpful for patients, and getting a baseline of where they're at, so that you can also compare where they are once they start the treatments to see if it actually is helping them or not. So having them do an initial voiding diary can be very helpful. So, what are treatment options? I mean, basically, you can do nothing. You can do lifestyle modifications, such as avoiding bladder irritants and doing time voiding. You can manage them with, incontinence products and diapers, bedside commodes for older folks. Sometimes they say that when they get up in the morning, they don't quite make it to the bathroom. So sometimes having a bedside commode there where they can just immediately void in the morning can prevent them from leaking on the way to the bathroom. This can be particularly important for older people who are at risk for falls. So if you have a wet floor and you're already prone to falls, that definitely increases your risk. Optimizing the health conditions I mentioned previously, such as diabetes. You can use medications, you can try physical therapy, there's Botox of the bladder, there's neuromodulation, and then when all else fails, there's actually surgical intervention, which I don't do that myself. I would send them to a reconstructive urologist for that. But this slide is this chart is just a nice overview and a brief summary of each of those treatment options. But I'm going to go into each of them in a little bit more detail. But this is just like a nice overview in a one pager if you ever need to use it for medical education for students. So behavioral therapy, this is doing things like stop drinking a gallon of water a day, avoid bladder irritants that can make OAB symptoms worse, like tea, caffeine, alcohol, artificial sweeteners, or highly acidic foods or drinks. I do find of that list, tea is like the worst culprit. So for whatever reason, the way our body eliminates tea, and it could be herbal, peppermint, caffeinated, caffeine-free, tea is just a real bladder irritator. So I always ask people, hey, do you drink tea? And a lot of them drink it right before bedtime. That's a pretty common habit. So having them cut out tea, a lot of patients will say they notice a difference just with that alone. Wearing incontinence pads rather than menstrual pads. I find a lot of patients are like, oh, I just use a menstrual pad, but those are actually designed to absorb more viscous fluid. So getting an actual incontinence pad, it absorbs liquid better, so it will keep them a little bit more dry. Using bedside commodes, as I mentioned, so if they have to get up at night, they're not leaking on the way to the bathroom or falling. Stop drinking 3 hours before bed. When they get a sudden urge, actually don't try and run to the bathroom, but instead squeeze the pelvic floor muscles for a count of 10. And this actually sends a signal back to the brain to get the bladder to relax, since it increases the tone of the urethral sphincter. Another way of doing this is like putting pressure on your perineum by sitting on your heel or sitting on like a tennis ball and putting pressure on that spot. It will actually send a signal to the bladder, get it to relax, and then people can then calmly walk to the bathroom before they start leaking. So pelvic floor physical therapists are very good at teaching patients some of these techniques and how to appropriately squeeze. So that's why physical therapy can often be helpful for overactive bladder. Another great option for women is vaginal estrogen. So one thing I'll put out there, unfortunately, estrogen has gotten a really bad rap. That now it seems to be the tides are turning, and HRT is all the trend now. But vaginal estrogen has never been shown to cause blood clots, cancer, stroke, or other complications that you see with the systemic estrogens or the oral estrogens or the patches. It's been found to be safe in long-term use. In fact, there are even some studies that show have compared breast cancer patients who use it versus those who haven't, and have not seen an increased recurrence rate in breast cancer patients who have used vaginal estrogen. But unfortunately, if you read the labeling, because it is an estrogen, it does have that black box warning that says, like, you can get a blood clot, stroke, or cancer. And so a lot of patients get spooked by that. But there are some GYN societies that are actually petitioning to get that labeling changed for the vaginal estrogen. But having said all that, the reason I say it is because vaginal estrogen has a ton of benefits. There are a lot of receptors in the urogenital tract, as I said, that respond to the estrogen therapy. And interestingly, the pills and the patches just don't seem to work as well, because I have a lot of patients that come in and they're already on the oral HRT, but they still have significant vaginal atrophy. So frankly, the vaginal estrogen for these conditions works just much better. We know that loss of the vaginal estrogen causes thinning of the epithelial cells. And sometimes in severe atrophy, you see just paper thin tissue there. And so they get loss of rugae, loss of elasticity, shortening and narrowing of the vaginal canal, which contributes to pain with intercourse. They have decreased subepithelial connective tissue. They have increased pH when you're postmenopausal because the glycogen content of the thin epithelium leads to a reduction in the lactic acid lactic acid that's produced by the lactobacilli in the vagina. So it results in an increase in the vaginal pH, which allows for increased colonization of bad bacteria. So you get a drop in that lactobacilli, and then an overgrowth of things like E. coli, staph, and Gardnerella, and even Trichomonas. So using vaginal estrogen can restore that pH and shift the vaginal flora back to the premenopausal levels, and that can help prevent urinary tract infections. So that's why it can help with bladder pain syndrome, it can help with recurrent UTIs, pain with intercourse, as well as overactive bladder. So for me, it's like one of my first go-to things because a lot of the patients I'm seeing have all of those things. So it can just be very helpful. There is ongoing research in the areas, particularly about bladder microbiomes, but it has been shown that going through menopause decreases the lactobacilli in the urine as well, which patients who have lower lactobacilli in their urine have higher incidence of like bladder pain syndrome and infection. A lot of that is still being researched, but that's kind of what preliminary findings have shown, that we know that urine really isn't actually sterile and there are a ton of different bacteria in it, but healthy urine tends to have more lactobacilli, which can be helped with the estrogen. So long story short, big advocate of estrogen for some of these symptoms. It can be very helpful for these women. There are a few formulations. There's vaginal, the estradiol cream. There's some suppositories, and then the E-string. I do find that the creams tend to work better than the suppositories or the rings. It might just be because it's messier and it gets to all of the tissues rather than just saying a little bit more localized, but it could be that the cream itself is providing some emollient properties that are helping with the health of the tissue. But either way, I do find that the cream formulations tend to help better with OAB and with recurrent UTIs than, say, the ring or the suppositories. With the cream, I usually have them, if they're medication naive, so they're just starting it, I have them use about a gram to about a third of that applicator full every night for 2 weeks. And then I have them use it 3 nights a week. So I tell them start out nightly because you want to kind of build up to the premenopausal levels and then sustain. I find a lot of patients are just given the cream and they're told, oh, just use it once or twice a week. And I see them and they still look atrophic. And I think part of that is because they're not, building up and then sustaining. They're just getting on this sustaining dose, and it's not really getting them to the level of repair of the epithelium that they need. So part of this could just be because I'm seeing more severe cases than the general population. But for me, I find that using it 3 nights a week tends to work a bit better for these folks. Next, we'll talk a little bit about overactive bladder meds. There are essentially 2 classes on the markets. The older meds are the anticholinergics. They work by blocking the action of acetylcholine, which is the neurotransmitter that triggers bladder contractions, and by inhibiting the effects of the acetylcholine, it relaxes the bladder muscle, which can obviously reduce the symptoms of OAB, like the urgency, frequency, and the incontinence. They bind to the muscarinic receptors in the bladder lining, and they prevent the acetylcholine from triggering the muscle contraction and subsequently allowing them to hold more urine and not have the bladder contraction. Having said all that, there is mounting evidence that there is a association with the antimuscarinic medications and the development of dementia. So there have been some meta-analysis looking at like 11 cohort studies and 3 case control studies. So basically almost 1.5 million patients. And they found that antimuscarinic medications were associated with an increased risk of all-cause dementia, with a relative risk, not huge, but like 1.2. So increased, not terrible, but increased. And that was found for regardless of the dose, so both low dose and high dose. They also think there may be a cumulative and dose dependent effect of those medications over time, meaning the longer you're on it, the higher the risk of the dementia. Another study showed that about 3,000 adults showed that a higher cumulative dose was associated with a risk of dementia, and they followed those folks over about 7 years. So, for these reasons, the dry mouth, the constipation, I'm not a huge fan of them. And then the long-term compliance with them, frankly, is not great. Usually, less than 30% long-term compliance of patients continuing these meds. But the problem is a lot of insurance companies require a trial of these medications before they'll cover other ones. So I don't think they define how long a trial is. So a patient, could have intolerable side effects, and you can say, well, they've tried that medication. There are some that cross the blood-brain barrier a little bit less, which are the fesoterodine, darafenacin, and trospium. And so those are thought to have less risk of dementia. So I tend to lean towards prescribing those first as a trial over some of the other ones, just for that reason alone. But there are now beta agonists on the market. There's 2, mirabegron and Gemtesa. So these are the second class of medication. The Gemtesa is a little bit newer. It's thought to have less impact on the blood pressure than the mirabegron, but it is significantly more expensive. So I find a lot of insurance won't cover it, or that their copay is just quite high with it. But they can be helpful. They're no more effective than the anticholinergics in terms of reduction of symptoms. But you do find a little bit better longer term compliance with them, probably because there's, less side effects. But basically it, inhibits the beta-3 receptors, which subsequently inhibits cholinergic activation and in turn relaxes the bladder. So those are kind of the newer meds out there. I'm finding a lot of insurance will cover the mirabegron, like it is on a lot of formulary for that. So when I have a patient who's new to medications, I always check to see if their insurance will cover that. And I tend to go with mirabegron as the first one. It comes in 25 and 50 milligrams. I tend to just go with the 50 milligrams because I find it more helpful rather than, ramping up the dose. The primary risk with it is potential elevation in blood pressure, but I find that rarely. The only real contraindication is people who have uncontrolled hypertension, and they define uncontrolled as like 180 over 110, so pretty darn high. So most patients are candidates to try it. I'll say I've probably had a handful of patients that I found their blood pressure went up and had to stop it as a result. But, for anticholinergics, as I mentioned, the most common side effects are dry mouth. That's reported by about 25% of patients. For trospium, sulfenacin, and tolterodine, and up to 44% with the oxybutynin. About 8 to 15% of patients will report constipation with these meds. There is a risk of incomplete emptying or urinary retention, and that's why it can be helpful to check their post-void residual first to make sure they don't already have retention. Retention can occur in up to 16% of patients, and then blurred vision in up to 11%. It can also cause palpitations, tachycardia, QT prolongation, which can cause torsades, de points, but That's all very rare. The extended release formulations tend to be superior to the immediate release ones in terms of less side effects. After starting them, you should kind of reassess after, no more than 8 weeks. I usually have them follow up in 4 weeks to see, one, how they're tolerating the side effects, but two, if the medication is actually working for them. Most studies show kind of the max benefit at the 4 week point. So if patients are like, hey, I haven't noticed any difference, then I'm just say, just stop it. Because at this point, if you tried it for 4 weeks and you've noticed no change, it's continuing it beyond that isn't gonna, provide you additional benefit. For the beta agonists, I mentioned they do tend to have a little bit fewer side effects than the antimuscarinics, particularly with the dry mouth and constipation. They also are less likely to have elevation in the post-void residual, so less retention. But the primary potential side effect is hypertension or potentially cardiac arrhythmia. With the mirabegron, the elevation was only found to be about 1 to 3 millimeters of mercury in blood pressure. So for most people, that's going to be clinically insignificant. But if you're comparing the anticholinergics with mirabegron and placebos, you do see a increased blood pressure, with the mirabegron, the beta agonist. So it's not recommended for use in severe uncontrolled hypertension, which again, they define as 180 over 110. Whereas viabegron does not have this warning. It's thought to be less of that side effect with the viabegron. But overall, the side effect profiles are very similar between the two. And again, the viabegron is usually more expensive. Next, we'll talk a little bit about Botox. This is one of my favorites. So it is a neurotoxin produced by Clostridium botulinum, which is a spore-forming anaerobic bacillus. It affects the presynaptic membrane of the neuromuscular junction, where it prevents the calcium-dependent release of the acetylcholine and basically produces a state of denervation. For Botox, the maximum cumulative dose has to be 400 units within a 3-month period for Botox or Botox cosmetics. I always ask patients, like, do you get it for cosmetics? Do you get it for migraines? Because you want to make sure you don't exceed that 400 units in a 3-month time period. For Botox, we typically start at 100 units. So 100 units is the standard dose for the bladder. We do give them prophylactic antibiotic to help prevent UTI for a few days after they receive the Botox. If you look at studies, they cite the need to catheterize due to retention as about 4% with the 100-unit dose. In my practice, I have not seen that. Like hundreds and hundreds of Botox patients, I have not had any of them need to self-catheterize due to retention. They have found that women who, with their first treatment, don't need to self-catheterize or pretty much never need to self-catheterize with subsequent treatment. So if they don't have that problem with the initial one, it's very unlikely that they are going to have it. So I would say in clinical practice, I kind of tell patients the risk of retention of them needing to self-catheterize is less than 1%. Of course, with Botox, there's no anecdote. So if you are in that 1% who are having difficulty urinating, your only option is to either wear a catheter or have to self-catheterize until you can void normally again. So that's why it's important to counsel them about it. But just in practice, it's very uncommon. The most common, complication with this is urinary tract infection. So that is why we give them the prophylactic antibiotic. Or they could have hematuria. You're poking the bladder with the needle, so they could have some blood in the urine afterwards. I'll say anecdotally that Botox, I find in terms of treatment options, is the one that probably gets the patients the most dry and that patients also continue to use, meaning they get repeated injections. It tends to last 4 to 6 months. I've seen it last as little as 3 and as long as 9. So it's variable with the patient. Um, so it's a nice option. The links are just to Botox itself, the website itself, and then there is a video, a little clip on how we do the Botox. But most insurance will require patients to have tried a medication, if not one, then two, prior to covering the Botox. But after you can show that they've tried the medication, I've not seen any insurance like deny coverage for the Botox. And then next there's neuromodulation therapy. So insurance will typically cover these after a trial of medication. There's a few different methods to administer neuromodulation therapy. Most studies show that electrical stimulation of the sacral nerve roots or the peripheral nerves operate by modulating the afferent nerve signaling. So it doesn't impact the efferent nerves, but the afferent ones. So it kind of has an indirect impact on the neural transmission pathways. I think the reality is no one knows exactly why these work. I kind of tell patients they tend to upregulate or downregulate receptors, meaning the electrical modulation is saying, look here, not here, kind of the way they work with like the pain stimulators that are implanted often for back pain. But what's interesting is with the sacral neuromodulation that you implant by S3, it can help not only with overactive bladder, but also with urinary retention. So it can help. That's really one of the only treatments we have other than catheterization for people who are having a hard time voiding. So for urinary retention. And it also helps with fecal incontinence as well. PTNS is percutaneous tibial nerve stimulation or neuromodulation. This is when you basically put an acupuncture type needle behind the tibial nerve. This nerve shares innervation with the sacral plexus that controls the bladder. And the patient comes in weekly for 30 minutes for 12 weeks. And then maintenance therapy is usually once every 3 to 4 weeks. The limitation, it does work, but the limitation is it's very, time consuming. So patients have to come to the office for it. So as a result, there have been developments of products that are implants over the tibial nerve. And there's a home PTNS device out there now that I'll talk about. And then lastly, there is TENS therapy. So some physical therapists have patients try the TENS units, which you can buy on Amazon for like $30, and placing them over S3. When you look at studies for the use of TENS for OAB, it's not been found to be as effective. And I don't know if that's just the devices, maybe don't send the same type of currency and frequency of the pulse width, but for whatever reason, the TENS, it may help some, but it's not found to be quite as effective as the tibial nerve stimulation or the sacral stimulation. So for the sacral neuromodulation, you place an implantable electrode through the sacral foramen of S3, and it stimulates the sacral and pudendal nerves. It's tunneled subcutaneously and then connected to the electrical or the internal pulse generator, which the rechargeable ones look like a USB port. They're about that size. And then the recharge free, meaning you put it in and then it runs out eventually, are a little bit bigger. They look more like the size of a pacemaker that you would put in the chest. Again, electrical stimulation of the afferents from the bladder and sphincter is thought to correct the, unbalanced neural signaling that occurs from the overactive bladder, which is why they think it can both inhibit the detrusor overactivity, but also activate it for patients who have the urinary retention. And this video is, if you go to minute 23, just shows you a demonstration of how it's placed. This is what the correct placement would look like on X-ray. So this is what we're aiming for when we're putting it in terms of the curve of the device. But the lead goes through S3, and then there are 4 electrodes that you can change the program so it stimulates different electrodes. If the patient finds that like one program isn't working, you can switch to another one, or even play with the different contact sites. There's a positive and negative charge. So you can alter that and program it if they find it starts becoming less effective. So that is one nice thing about the sacral ones. There are essentially two brands out there. There's one by Medtronic and one by Axonics, and frankly, they're equally effective and they work the same. They are MRI compatible now, which is really nice. It used to be that once you got these in, you couldn't get MRIs. And this just shows the rechargeable one and the recharge free is what they call it. The batteries used to only last 5 years. Now the rechargeable one, they quote 15 to 18 years, and the some studies say up to 20 years. Just depends on how much amplitude is required for the stimulation. Lower amplitude, the battery is going to last longer. But the recharge free used to only be 5 years, and you'd have to switch out the battery. Now it lasts like 15. So they're much better than what they used to be, which is a great evolution of those, because switching out the batteries, obviously you have to go to the operating room to do that. And then again, Axonics is essentially the same. Their battery is slightly smaller, but otherwise it's put in the exact same way, in the exact same location. They have a rechargeable one and a recharge-free one as well. And then there are some newer devices on the market that, as I mentioned, are kind of derived from the PTNS therapy. So companies, quickly realized that sustaining the in-office PTNS was very difficult for some patients. And so essentially they've created ones that can be done at home. Medtronic, I think 2 months ago, just their device was FDA approved. It's called AltaViva, and this is about the size of a USB. You can see in that photo, it literally looks like a USB device, and it sits over the tibial nerve. And that one has the battery and neurostimulator all in one. It acts on its own, so the patient doesn't have to like actively do anything to use it. It automatically activates for 30 minutes 3 times a week. So there's no like controlling that the patient has to do to turn it on or anything. And the battery supposedly lasts for 15 years. But it's only rechargeable, so they have to recharge it once a year. It is only indicated for urge incontinence, however, so not overactive bladder. It's for you're wet, you're leaking and you're wet. So that is the only FDA approved indication for this device at this time. There is Revy. Now, we don't have the AltaViva at Sibley yet, but we do have the Revy. And that one it looks like just like a little small bullet that goes over the tibial nerve. So the only thing that is implanted is the little bullet device. And then this does require some patient commitment, because they wear this. I joke that it looks like a house arrest bracelet, but it's a neoprene sleeve that has the stimulator in it, and they wear it over that little implant. So they do have to use it every day. So this cuff, essentially, they need to use it an hour a day. Then after 12 months, they're looking now at the maintenance therapy and finding that people can probably use it a little less frequently. It just depends on the patient. So they kind of leave it up to the patient after that, like how often they want to use it. Some patients find they still need to use it every day, but they can only do 30 minutes. They only need to do 30 minutes. Some patients find they can do it 3 days a week and still have benefit. So this device works really well, but it does require the patient to use it for it to be effective, of course. They do define success as a greater than 50% reduction in their symptoms. You do see about a 30% dry rate with this. So for patients who have overactive bladder wet, we call it, or actual the urge incontinence, they have about a 30% chance of being dry with that. And then lastly, there's the Valley. This is an at-home device. It's basically the PTNS, but the patient does it at home. And so it's just a little neoprene kind of sock that has this stimulator that fits into the sock. They wear the stimulator over the tibial nerve, and they put on a little, almost like a little EKG sticker over the ankle so it conducts, and it sends the electrical nerve signals through that. It kind of feel I've tried it. It kind of feels like when you've been sitting on your foot for a long time and then it starts to wake up. It feels like a tingling sensation in your foot, like after your foot's fallen asleep. That's essentially what it feels like. The device itself, the issue is not all insurance will cover it, and of course, again, the patient has to use it. So I haven't had a lot of patients opt for this yet, but if you, sorry, I didn't realize I wasn't on the slide. This is the Vivale, so the neoprene sleeve, and then the little charge device. But it's supposed to be just as effective, like as the PTNS, but the device itself is about $5,000 if you were just to buy it outright. They are finding more insurance is covering it now, and the patients have to pay about 20%. So this cost information is directly from the company. So if their insurance covers it, they'll end up paying about $1,000 total for it, or $83 a month until they own it, right? If they don't have insurance, they can pay $139. They put $300 down, and then they pay $139 a month, or they can just buy it outright. So for some patients, this may be cost prohibitive is the downside of this device. But the company says you use it for 30 minutes 3 times a week for it to be effective. And again, the standard is 50% reduction in symptoms. So I don't personally have a lot of experience with this one, but it's supposed to be as effective as the in-office PTNS. And then lastly, for really refractory cases, there are, surgical or more invasive options. Catheters, if the patient just can't stay dry. This is definitely not a preferred choice, just because indwelling catheters can certainly cause UTIs, urethral dilation, long-term use, increased risk of actual bladder cancer. The patient can start leaking around the catheter. So I do have some patients that I've had suprapubics in. Usually those are like cancer patients, but a suprapubic is slightly preferable because you won't get the urethral dilation, but you still have the same issues with infections and increased risk of bladder cancer. Ironically, sometimes get overactive bladder from the catheter itself. So it's not an optimal option for treating refractory overactive bladder. So there is some surgical options where you can augment the bladder with a piece of the ileum. So if they have a really low capacity, if that's their issue, you can do bladder augmentation, or you can do urinary diversion, either a continent one where you kind of make a neobladder, and then they have a stoma that they catheterize, usually through their abdomen. Or you can have an incontinent one where they essentially have an ileal conduit that just drains directly to a bag. So those are options for really severe cases. I have only, as of yesterday, I have one patient that I have referred to a reconstructive urologist as to have this discussion about whether they would be a candidate for this. So, most patients, either their leakage isn't so bad that they would want to go through this. And obviously it's, changes your quality of life when you have a surgery like this. So definitely kind of a last resort in terms of treating, severe refractory incontinence. And then, lastly, we'll get to, when should you refer? So the textbooks say, basically refer for these reasons. If you think it's anything other than idiopathic overactive bladder, you should refer. So obviously, if you suspect, a underlying neurologic reason, they're complicated, they have recurrent UTIs, they failed basic medication, those are patients that you should definitely refer. But my shorter answer is you can refer anytime. I'm happy to see any of these patients. I don't have, even if they haven't had a trial of medication, you can always refer. I don't expect anybody to manage the patients. That's what I'm here for and trained for. So if it's something that you don't feel comfortable treating, I'm happy to see them, even if they've not had any prior treatment or anything. It's nice for them to have had a urinalysis before they come, just to make sure they don't have a UTI. But otherwise, I don't want to manage anyone's blood pressure, so I don't expect other people to manage patients' overactive bladder. So if you remember nothing from this long-winded lecture, I would just say don't hesitate to refer. Don't forget to ask about their fluid intake. So, what are they actually drinking every day? Check for a UTI. Estrogen for females, it's kind of a wonder drug for a lot of different conditions. So don't forget about the vaginal estrogen. Consider a trial of medication. Consider the potential risks of dementia with long-term use with the anticholinergics, and then ask the patient if it bothers them. Because I will say I've had a few referrals where sometimes I think, especially if the patient is under the care of a family member and they're incontinent, it bothers the family members. And I've had patients, come and we talk and they're like, it doesn't really bother me. I just pee in my diaper, and have literally said that to me. So if it doesn't bother the patient, and it's not causing skin irritation from being wet or, anything like that, then doing nothing is an option. So sometimes I do think, unfortunately, the families are sending the patients more so than the patient is sending themselves. So I always ask them about that as well. My contact information is here, so you can contact me directly. You can email me if you just have a question. You can use my cell phone. I have a clinic in this lovely location in Arlington, Virginia now. It's in Ballston. It's right where the Capitol's Iceplex is. So we're on the second floor. The Iceplex is on the 8th. Ample parking, costs $1 to park. I am starting in November. We'll be seeing clinic at Sibley 2 days out of the month. So just 2 days. The rest I'm either operating or at Arlington. But this is just a photo of the lovely new. This is the lobby of the clinic, and it's a multidisciplinary clinic. So we've got ophthalmology here, colorectal surgery, OBGYN, cardiology. We've got some surgical oncologists that come here and see clinic. Of course, urogynecology, internal medicine, primary care. I think that is all the specialties. I might be missing some, but I think that's all of us. So, and most of those providers are also accepting patients as well. So I will stop talking and open it to any questions.